Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 45th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I am a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, Partial or Total Knee Replacement, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on the IBJI and NSYMCA websites. If you've investigated knee replacement surgery, you've probably discovered that there are two options: total knee replacement and partial knee replacement. Tonight, Dr. Mark Anjourame will explain the differences between the two surgeries, as well as the reasons physicians might recommend one option or the other for individual patients. In addition, he will discuss less invasive arthroscopic knee surgery options for people for whom knee replacement isn't recommended. I am pleased to introduce Dr. Mark Anjourame, MD, an Illinois Bone and Joint Institute board-certified orthopedic surgeon with fellowship training in adult reconstruction and hip and knee replacement. Dr. Anjourame specializes in both total and partial knee replacement, along with direct anterior approach total hip replacement. His areas of focus also include complex, revision hip and knee replacement, arthroscopic knee surgery, and meniscal surgery. He is also interested and invested in research through which he has received numerous awards. Dr. Anjourame attained his medical degree from the Loyola University Chicago Strick School of Medicine, where he graduated cum laude with honors in research. He then completed his residency at Carolinas Medical Center and OrthoCarolina in Charlotte, North Carolina. In addition to working at one of the top 5 busiest trauma centers in the country, Dr. Anjourame also worked with world-renowned hip and knee reconstruction experts. During fellowship training in Denver, Colorado, under the tutelage of Dr. Douglas Dennis, he focused on primary or first time and complex revision or not first time hip and knee replacements, helping patients who had serious problems with their original prostheses regain mobility. Dr. Anjourame continues to gain satisfaction by helping people who've had trouble with their prosthesis reclaim use of their joints. Problems with joint replacements can be debilitating and incapacitating for people, thus causing them to lose mobility. What Dr. Anjourame finds most satisfying in his job is restoring that mobility and that independence to patients, especially those with problematic joint replacements. In fact, Dr. Anjourame says that he chose orthopedics because it not only allowed him to use the technical skills that he learned as part of the profession, but also gave him an opportunity to use his critical thinking skills to create algorithms and develop strategies to work through possible diagnoses and to find solutions for his patients. Dr. Anjourame contributes the exceptional care that his patients receive to the well-oiled machine that is his team with IBJI. He says that in the team approach, you're only as good as your weakest link. However, Dr. Anjourame says that his team has no weak link, which is why when you read Google ratings, he and his IBJI team consistently receive 5-star reviews. Dr. Anjourame's goals are finding treatment plans to help his patients reach their goals, whether they want to return to athletic endeavors, walk around the block with a friend, or simply pick up their grandchildren. It's no wonder he receives top ratings. During Dr. Anjourame's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the question section on your screen, and I will receive them and relay them to Dr. Anjourame immediately following his presentation. I do ask that you please keep your questions general, as Dr. Anjourame will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Anjourame via one of the options that will be listed on the slide shown during the question and answer portion at the end of his presentation. One last thing before I turn the evening over to Dr. Anjourame, I invite you to mark your calendars for our next IBJI and YMCA Education Series program. On Tuesday, October 24th at 7 p.m., Dr. Amy Jo Ptaszek will cover the treatment options for bunion pain. Thank you all again for joining us tonight, and thank you, Dr. Mark Anjourame, for your time and your effort in putting together this program to help us answer the question, partial or total knee replacement. Dr. Anjourame, please take it from here.
Well, welcome everybody, and thanks for having me into your homes tonight. My name is Mark Anjourame, and Karen, thank you for the introduction. Really appreciate that and all the kind words. Tonight we are going to talk about osteoarthritis. We're going to discuss non-surgical treatment strategies as well as surgical treatment strategies encompassing both partial and total knee replacement. A little bit about me, and Karen addressed much of this, but I'm a fellowship-trained orthopedic surgeon. I specialize in complex and revision joint replacement surgery on both the hip and the knee. I trained with OrthoCarolina and Carolinas Medical Center in Charlotte, North Carolina, and then under the tutelage of Dr. Doug Dennis out in Denver, Colorado, I completed my fellowship in joint replacement at the Colorado Joint Replacement Institute. Currently, in practice, I am at Illinois Bone and Joint at 2 locations in both Barrington and Algonquin, Illinois. My clinical practice is largely made up of non-operative management of arthritis, then total and partial joint replacement on both the hip and knee side, as well as fracture management and arthroscopic management of knee issues. Other professional interests that I have includes research. I've started and currently am the head of the Illinois Bone and Joint Research and Education Institute. I've published 32 studies, case reports, technique articles, as well as reviewed articles in a book chapter. Additionally, beyond research and taking care of patients, one of the passions that I have is Operation Walk, which is a organization that has several locales across the country that provide mission work where we bring joint replacements and carry out joint replacement surgeries for some of the most impoverished in the Western Hemisphere. And up in that corner there, you can see a patient and myself following a surgery in Honduras. And that whole operation and Operation Walk has a special place in my heart. Before we get into partial versus total knee replacement, I'd like to just establish a baseline of what arthritis is. And what I tell every one of my patients that comes into the office seeking consultation or wanting to discuss knee or hip replacement surgery for that matter is what is the definition of arthritis? And it is the loss of cartilage that God gives us at birth. So we're blessed with a certain amount of cartilage in all of our joints, from our finger joints to our hip joints to our feet. And it's no different with our knee and hip. And much like the tread on a tire, on the far left, you can see a full tread of tire, and then as you progress to the right, you can see progressive loss of that tread. And much like a tire, which would cause dysfunction to the vehicle and steering, it would, the loss of cartilage causes dysfunction in terms of pain and swelling and deformity to a knee or a hip joint. And so then we consider replacement when it gets bad enough. On your left here is a picture of a chicken bone. On the right is an arthroscopic picture of a knee joint. And so you can see the cartilage is actually very similar. On the left, there's no cartilage wear. On the right, you can see the salmon pink colored bone underneath the cartilage that has been lost. The white pearly substance is the cartilage. The salmon colored substance is the bone underneath the cartilage, that's there to support the cartilage. And once that's gone, there is no getting that back. There is a lot out in the literature, or out in the community, I should say, regarding restoration of cartilage through injections. But the reality is that we do not have that technology to reliably and predictably restore that cartilage to date. The reason why is that salmon colored substance there does not have a significant blood supply. And so for that reason, the white pearly substance, the actual joint cartilage, does not have a blood supply upon which to grow. And so that's an important thing to understand, that once that cartilage is gone, and in such magnitude that we will see and talk about later in the talk, there is no getting that back. And therefore, if we are having symptoms, we discuss injection therapy or replacement therapy. A little bit more about arthritis. It is the most second common chronic condition in the United States to date. 20 to 30% of people over the age of 70 suffer from symptoms of osteoarthritis of both the hip and the knee. And currently, the costs are upwards of $80 to $85 billion a year, including hospital and drug costs, nursing home costs, and lost monies in terms of productivity and work. So it's important to see, when I evaluate a patient in clinic, one of the things we always do is get an X-ray. And on that X-ray, patients always want to see where the arthritis is. And I show this in terms of both the knee on the left and the hip on the right, in terms of trying to show you tonight what I see on an X-ray that causes me to tell a patient that you have arthritis. Arthritis is not corrosion. Arthritis is not something that is added to a knee or a hip joint. It is actually the loss of something. And again, it is the loss of cartilage that God blessed us with at birth. On the far left schematic here, you'll see in the depiction normal joint space. We should normally see between the two ends of the knee joint, the top end is your thigh bone. The bottom part of that joint is your leg bone, also known as the tibia. We should see a space of about 6 to 8 millimeters. That space represents cartilage. Cartilage does not show up on an X-ray because it is not ossified like bone is. It's not calcium, it doesn't have the calcium like bone has. And so we see it as a black space. Well, when we don't see that black space anymore, we know that you have lost the cartilage that you were blessed with at birth. And so therefore we can say that you have, like that middle picture, you have severe arthritis. This is what depicts bone on bone. If you've heard that moniker in the community, that tells you that you have lost all of the cartilage that God blessed you with at birth. Similarly, if you look at this picture of a pelvis where you see both hip joints, on the right-hand side of this X-ray, you can see a normal hip joint. You have normal joint space on the right-hand side of the screen. But on the other side of that pelvis X-ray, you can see that the ball of the hip socket, or ball of the hip joint, is kissing the cup or the socket of the hip joint, and that again is consistent with bone-on-bone arthritis. So if you have arthritis, you are not alone. This is a study that was completed. This was a projectional study completed in 2007, published in one of our top-tier orthopedic journals, the Journal of Bone and Joint Surgery. And this discusses what the approximate number of procedures would be as the years progress. And this is taking into consideration an aging population as well as a booming population. And we see nothing but an increase in terms of not only arthritis, but also of knee and hip replacement surgeries. So again, knee arthritis is cartilage and possibly bone erosion. This leads to deformity, which we will discuss next. So much like the wheels on a car, they can turn inward, they can turn outward, they can toe in, or they can toe out. And similarly, our knees can do the same. On the far left-hand side of the screen, you'll see a normal alignment of a leg. In the middle portion of that screen, you will see the bow-legged or cowboy deformity, as we will sometimes call it. And then on the far right of that schematic, you'll see the valgus deformity, which is knock-kneed. And again, there is nothing that you have done or anything that you have that may have caused a particular deformity. It's truly how God intended it to be. But every moment that we walk, we are losing cartilage. It's a no-sum game, so to speak. It doesn't have the ability to restore itself, as we discussed previously. And as you wear it out further, it almost potentiates and almost accelerates in terms of the loss of cartilage. And then you end up developing one or two of these deformities, either bow-leggedness, which is varus, or knock-kneed, which is valgus. Here is an example of a total knee replacement that I completed. And you can see we're talking about a left knee, which is actually on the right side of each picture. And this knee was bow-legged to start. After knee replacement surgery, the alignment was corrected to neutral alignment. What are some of the symptoms of arthritis? Well, sometimes patients limp. Their joints feel stiff. They've noticed progressive loss of motion within the joint. And it's difficult because of those things to walk, to complete household chores, or even sometimes tying shoes. They have pain at night. They have a difficult time walking even 2 to 4 blocks, which is a quarter to a half mile. One leg might feel shorter due to a developed deformity. And you will experience, especially with hip arthritis, you'll experience pain in the groin or the front of the thigh, and with the knee, you'll experience pain in the front of the knee or diffusely about the knee joint. So the first things first, we always try non-operative management, and I have to walk patients through this on a daily basis. And these are the non-operative management options in 2023. This has been the same since the late 80s. The first things is that we talk about activity modifications. If a patient comes in a clinic and they say, I just can no longer run my 5K or my half marathon, I'd say, sir or ma'am, we have to develop and think about and carry out a different exercise strategy so that you can maintain the principles of aerobic exercise. Weight loss is incredibly important. If you have weight to lose, I tell patients 1 pound above the belt is felt 4 pounds on the knee while walking on flat ground. When going up and down stairs, that 1 pound above the belt is felt 7 or 8 times that number, 7, 8 pounds on the knee when going up and down stairs. So that can have a dramatic difference. You lose 5 pounds when just walking on flat ground. That's 20 pounds off your knee, so to speak. That will improve symptoms, but it's not going to solve the issue, but it will improve symptoms. Cane or a walker, that's the reason why canes and walkers were developed. I mean, the first knee replacement went in 1963. That was in New York City. Canes and walkers were developed and utilized largely before then to deal with these issues that we have today. So this is truly in the entire spectrum of humanity. Modern day knee replacement and hip replacement is a luxury. Physical therapy can be helpful, especially when we need to build up the quadriceps muscle to improve the strength when trying to get up out of a seated position. But make no mistake, physical therapy is not going to restore the cartilage on the knee joint. A common misconception is that the patients present to clinic and they say, I need some physical therapy to strengthen the muscles around the knee joint. Well, there really aren't any muscles around the knee joint. It's tendons around the knee joint that are connected to muscles in the thigh. And so, I believe physical therapy is important for improving quadriceps strength, which helps mobility, but it will not improve the pain in your knee due to the loss of cartilage. Medications, the mainstay of treatment for arthritis is Tylenol and a non-steroidal anti-inflammatory. Injection therapy consists of 2 types of injections. One is a steroid injection and the other is a viscosupplementation injection, also known as the rooster comb shot or the gel shot. And so those are 2 types of non-operative injection therapy strategies that we carry out in order to help with the symptoms of arthritis, but not cure arthritis, because those injections, again, do not restore the cartilage that you have lost on your knee joint. When we talk about modifiable activity or modifiable treatment strategies, really weight loss and activity modifications are things that you can easily do in order to improve the symptoms of arthritis. The other 4 non-operative treatment strategies need to be carried out, and so those are therefore not modifiable. But things that you can do tomorrow would be weight loss and activity modifications. An example that I always talk about in clinic is, if you're a singles tennis player, an activity modification that can be carried out is doubles tennis. And so I know that seems simple, but another, analog would be, instead of, playing 18 of holes of golf and walking the entire course, you're taking a cart. Instead of running a 5K, you're walking a 5K. Instead of walking, you're utilizing an elliptical or a stationary bike. Those are all things that you can do that are going to lower the impact on the knee joint and thus reduce your symptoms. Then we get into operative treatment strategies. So when the conservative treatment strategies have failed, we move into the surgical realm. And the surgical realm consists of partial versus total knee replacement. And this is an example of a total knee replacement. We'll talk about the partial knee replacement here shortly. So when should a patient be considered for partial or total knee replacement? And I'd say it's different for each patient. It really is a quality of life decision. And usually I help draw the line in the sand for the patients by saying, when you can't walk more than 2 blocks without pain in your knee, when you're finding that you are not wanting to go for that walk for exercise, or go downtown on a shopping trip with your daughters, or run around with your grandchildren, that because of knee pain, you're worried about the ramifications the next day of pain and swelling, then you're to that point. Other lines in the sand are night pain and pain when going up and down stairs. I try to coach patients to not pull the trigger too soon on a knee replacement, but also not let it get too far to the point where they kind of do a disservice to their exercise tolerance and lose that endurance, which takes months to years to build back. And I always tell patients that X-ray findings are not the most important factor in the decision. There are many patients that have bone-on-bone arthritis who don't have significant symptoms, and therefore they're able to live with it. Other patients have moderate arthritis and have more symptoms than the patients with the bone-on-bone arthritis, and it's all based on symptoms. Surgery should be considered when the patient has exhausted all reasonable conservative management strategies. And that doesn't mean that you have to undergo injection therapy, does not mean that you have to undergo physical therapy, or you have to lose a certain amount of weight. It just means that we've tried that. And truly, it's through a dichotomous talk in clinic about where the patient's at, how it's limiting their quality of life, are they able to sleep, and it has to be commensurate with their X-ray findings of severe arthritis. Not quite bone on bone, but near bone on bone. So patients should expect with knee replacement surgery a preoperative medical evaluation. Most knee replacement surgeries are carried out same day, meaning you go home the same day after surgery. If you have medical issues or feel uncomfortable, a 1 overnight stay usually suffices. Most postoperative therapy at this point in time, or in this modern era, is outpatient, meaning you go to the outpatient physical therapist, which provides aggressive early physical therapy. A lot of you might have talked with friends or family, regarding some of the trials and tribulations of knee replacements, and they know everybody talks about the first couple of weeks. I believe that one of the keys to a fast and quicker recovery is early range of motion. And I believe that limits that pain and stiffness and swelling in the first couple of weeks. Most patients are usually using a walking aid from just a few days to a couple of weeks, and that might consist of a cane or a walker. And patients are weight bearing as tolerated after surgery, meaning that if you could put weight on the limb, then you put full weight on the limb. Some of the limitations with joint replacement is that I ask patients to avoid repetitive high impact activity. And what that means is running. Everything else from mountain biking, hiking, hang gliding, gardening, motocross, boating, fishing, whatever you'd like to do besides running is encouraged. Running in and of itself, if you're going to run to save a child from a burning building, I say get on your high horse and get there quick, and you'll be able to do so. But repetitive running for exercise, the pounding on the plastic portion of the knee joint, which I will discuss with you a little bit later tonight, won't be good for the plastic and limits the longevity of the knee replacement. I encourage all my patients to return to an active lifestyle, including skiing, wakeboarding, and whatever they would like to do. This is a picture of when I was in fellowship of knee replacement patients who hiked a 14er, meaning 14,000 feet, and this was at the climax of the mountain, and very, very special. All these patients had knee replacements, and they were able to hike 14,000 feet. And so if they can do it, you can do it. The longevity of the knee replacement, that's one of the most common questions to ask, whether it's a partial or a total knee replacement. How long do they last? Some older doctors will say you'll need a redo in 10 years. We got to go in for a tire change, and we have to change out that plastic piece. The current literature does not support that statement. The current literature suggests 20 to 25 years. And to be honest, my gut instinct tells me, based on the data I have seen back so far, that the latest generation plastic that debuted between 2007 and 2009 will get 25 to 30 years of longevity. So let's get into the meat of the talk tonight, which is a partial knee replacement versus total knee replacement. And we use some of these terms interchangeably, not so much for total, but for partial. And the partial, you'll hear discussed as uni, meaning a unicompartmental one compartment, versus a total knee replacement means all three compartments of the knee. And I'll get into that next here. So the knee, a native knee, has three compartments, and it consists of the medial compartment, the lateral compartment, and the patellofemoral compartment. Patients can have arthritis in one, two, or all three of these compartments. So a uni is a replacement of a single compartment or area, and these X-rays demonstrate the top two consist of a patellofemoral joint arthroplasty, meaning the kneecap compartment, and that was for arthritis that was only in that portion of the knee joint. So we replaced just that portion of the knee joint. The bottom two pictures depict medial compartment arthritis, a replacement for medial compartment arthritis, and this is the most common type of partial knee replacement, which is a medial unicompartmental partial knee replacement. Therefore, a total knee replacement is when we replace all three compartments. And these are the two types of knee replacements. Now, the picture on the left is a unicompartmental medial replacement. This is not the patellofemoral joint replacement, but this replaces one compartment of the knee. The knee replacement on the right is a total knee replacement, meaning that it's a resurfacing of all three compartments of the knee. And in either circumstance here, either the left or the right, whichever compartment you're replacing, this isn't like we're lopping off the knee joint. What we are doing is taking millimeters of the bone that should support the cartilage that God gave you, that you have lost over the years. We are taking that bone away and replacing it with metal and plastic. That plastic piece that I was discussing, and you can see it most definitively on the right-hand portion of the screen here, is that white substance between the two metal pieces. That is made up of a highly cross-linked polyethylene, which is a highly complexly engineered plastic that is incredibly resilient, and that's what we're getting 20 to 25 and potentially more years on to date. So what's better, a partial knee or a total knee? Well, first I want to look at, I want you to understand what I take into consideration, what I hold most to my heart in terms of research data, and that's the registry data. And to put it in context, I'm going to be showing you several non-American registries. And the reason why we do this is that for historical purposes, the United States has not had a registry that has been mature to be able to draw long-term data from. Now, we are getting to that point with the American Joint Replacement Registry. But some of the countries that have tracked this have had universal payer systems, and therefore they track their data incredibly well. And so this is where we garner the majority of our long-term data from. And this is a slide showing, years on the bottom and survival probability on that y-axis. And as we progress out in terms of years from the left to the right, 0 years to 8 years, we see the probability of survival of not the patient, but of the knee replacement, meaning that they did not need a revision knee replacement. And so you can see the red line is the partial knee replacement, and the blue line is the total knee replacement. And this would tell you that the survivorship, at least to 8 years, is statistically higher with the total knee replacement. And we'll get into why later, but I just want to go over a few other registries. So this is the Swedish Knee Arthroplasty Registry, looking at a multitude, thousands of knee replacements, both partial knee, the UKA, and total knee, the TKA, and they stratified it, interestingly, based on age. And they looked at what are the revision rates of knee replacements, either partial or total, for patients less than 55 and over 55. And you can see there is, in both categories, there is a higher rate of revision surgery at 10 years with a partial knee replacement. That seems to be the theme, and it's corroborated and commensurate with the finished joint registry. So again, the partial knee replacement has a higher revision rate and consequently a lower survivorship at 5 years, 10 years, and 15 years. Partial knee replacements fail because of you're only replacing one of 3 compartments of the knee joint. And so that means you could technically have arthritis and go on to worsening arthritis around the knee joint in the other 2 compartments that are not resurfaced. But a good partial knee replacement for the right indications will last you a lifetime. And so the key is trying to figure out which patients, based on their patterns of arthritis, are going to have success long-term with a partial knee replacement and not a full or a total knee replacement. And so one of the landmark studies that we still use for treatment or for indications for patients with partial knee replacements is that they need to have evidence of full thickness medial cartilage loss. They have to have intact ligaments, meaning that the ACL is still competent, meaning it's taut and it has the full thickness of its fibers available. Activity levels have no difference in terms of survivorship. The age has no difference in terms of survivorship. There's no difference in survivorship in terms of age or activity levels, and that's important to know. I have no problem doing a partial knee replacement for the right reasons on somebody in their 40s, and I have the same confidence that a partial knee replacement would help that patient in their 60s, 70s, or 80s. But where I draw the line is based on whether or not the ACL, your anterior cruciate ligament, is intact, and whether or not you have arthritis underneath the kneecap. So what we are left with is a good pool of patients, for the most part, that have arthritis in one compartment of their knee. And this was a study done in 2017 that looked at thousands of patients, and they felt that 50% of patients can be treated with a partial knee replacement. Partial knee replacements, again, need to have no evidence of lateral compartment disease. So the outside portion of the knee joint, which is closest to the fibula, which is the smaller bone to the side of that knee there, that joint space needs to be well maintained. The other joint space needs to show near bone-on-bone or bone-on-bone arthritis. What are the advantages of a partial knee versus a total knee? Well, The partial knee, and this is where the crux of it lies for you. If a patient is a candidate for a partial knee replacement, I will do a partial knee replacement. Why? It's largely because it feels more natural for the patient. In a partial knee replacement, the anterior cruciate ligament, or the ACL, is preserved. The mechanics of the knee require that the ACL is preserved, whereas in a total knee replacement, the ACL is taken out. The partial knee replacement is less invasive. It preserves more of God's bone stock, and it offers a faster recovery, both in terms of return to activities of daily living, but furthermore, it's a shorter hospital stay. Again, most of these patients go home the same day. There's less blood loss, there's less risk of infection, there's less risk of blood clots. The disadvantages of the partial knee replacement, as we pointed out with the registry data from England and Finland and Sweden, shows a higher rate of failure. And the reason for the rate of failure, again, is the progressive loss of cartilage in the other compartments that were not restored or revised. So again, based on data, you'll see three studies here that are landmark studies that we look to for reasons to carry out procedures or not to carry out procedures, but we're always looking towards the research. And these studies show better range of motion, shorter lengths of stays, higher patient-reported outcome scores at 6 weeks. There's no difference between those patient-reported outcomes in terms of pain, however, but there's lower risks of mortality, blood clot risks, and cardiac events with a partial knee replacement. And again, to sum it up, it's a smaller incision, it's less invasive, it preserves bone and ligaments that the knee replacement would not otherwise preserve. There's less blood loss, there's less initial post-op pain, and the studies seem to suggest that the forgotten joint score, meaning the day that you can wake up and not realize that you had a joint replacement, is shorter with a partial knee replacement as opposed to a total knee replacement. Bottom line is that a well-done partial knee replacement within the guidelines for partial knee replacement will be long-lasting and forever with a more normal feeling knee. But not every patient has the criteria that meet the criteria for a partial knee replacement. That's important to understand. Total knee arthroplasty has a higher likelihood of being a one and done surgery for you. Both types of replacements, however, will improve your quality of life if carried out with impeccable surgical technique and for the right surgical indications. In my practice, 8% of my knee replacements are partial knee replacements. That is a little bit higher than a study published about 3 years ago showing that about 6% of patients demonstrate the criteria for partial knee replacements. I do about 5 patellofemoral joint arthroplasties a year. That's a rarer type of partial knee replacement. I have no reoperation with either partial or total knee replacements, and I have no manipulations under anesthesia for partial knee replacements. 100% of my partial knee replacements are same-day discharge. I'm currently at about 60% of same-day discharge for total knee replacements. I employ physical therapy in the outpatient setting for the sake of getting patients on an accelerated path to recovery, which lies entirely with aggressive physical therapy. By 2 weeks, I expect most of my patients to have 110 to 115 degrees of flexion, and I have no restrictions for patients after 6 weeks with either total or partial knee replacement. So that sums up my talk tonight. I encourage any questions that you all may have, and I'm happy to answer any of them.
All right. Well, thank you. very much, Dr. Andrum. That was really clear, concise. I loved the way you had the chicken bones because it really shows people what the cartilage looks like. And you know, you've seen chicken bones, but to really think about it and understand that the cartilage you get is that you're born with is the cartilage you get. I thought that was really a very cool way of showing that. Okay, so here come our questions. I'm going to kind of mix them up because, you know, some come in earlier, but then I go, ooh, what about this? Because we had a couple of good questions. Is a partial knee replacement, you mentioned the patella part and the medial partial knee replacement. And Catherine asks, do you ever do the lateral side partial knee replacements?
Yeah, so lateral compartment partial knee replacements is certainly possible. I have done them before. It is rare though. And the reason why it's rare is because the medial collateral ligament is, in my opinion, the most important ligament for the solvency of any type of knee replacement. And when you fall into a knock-kneed deformity, which is when you would wear away the cartilage on the lateral side of the knee joint, you end up stretching that medial collateral ligament. And so one of the failures of lateral compartment partial knee replacements is instability. And for that reason, I think patients with advanced disease in terms of lateral compartment disease, isolated lateral compartment disease, are better off with a total knee replacement because I am more able and more apt to be able to appropriately tension the medial collateral ligament, giving your knee a more stable feeling. And so that's possible with a partial knee replacement. Lateral compartment arthritis, it's difficult. And we're seeing less and less lateral partial knee replacements completed as we move on in the years with partial knee replacement.
Got it. That makes a lot of sense.
Great question.
Yeah, it was, yeah. And Beata asks another interesting question, which is, no one's ever mentioned to her before about the ACL being removed in a TKA or in a total knee replacement. Can you explain why the ACL needs to be removed for a total knee replacement?
Sure, because with a total knee replacement, we resurface both sides of the top portion of the knee joint. And I describe it as a golf ball and a golf tee. The golf ball is the bottom part of your thigh bone, and the golf tee is the top part of your leg bone. And so when we replace both sides, we resurface the entire tibial plateau. Or the entire top portion of that golf tee. Where the ACL inserts on the tibia is on the front portion of that golf tee. And so because we have to resurface both sides, the ACL attachment has to go, and therefore the ACL is no longer functional. So the ACL is routinely, and it's the gold standard with most joint replacements, most total knee replacements, no matter the company, that the ACL is taken out at the time of surgery and made up for by the implant design.
Okay, got it. Thank you. Jessica asks, can one go from a partial to a full knee replacement if needed?
Yes, it's a great question, Jessica. And one thing I did not include in the talk, but this question begs the discussion of it, is that patients will often utilize or think about a partial knee replacement as a stepping stone to a total knee replacement. It will afford them a few years of a more normal feeling knee in a less invasive fashion compared to a total knee replacement, which they may not need yet. The problem is that going from a partial to a total in terms of patient satisfaction scores and your reported outcomes is not as high as if you were to do the total from the get-go.
Got it.
And so that's it. And what I mean by patient reported outcome satisfaction, you can understand, you just have higher satisfaction scores. It feels more normal. There's less pain. There's less stiffness. You got to consider going from a partial to a total is a revision knee replacement surgery. There's more scar tissue. There's a higher risk of complication. and ultimately the patient-reported outcomes are less, meaning that your gait stride length, the gait velocity, your ability to get from a sit to a stand is faster with a total knee replacement from the get-go as opposed to a total knee replacement that has been revised from a partial.
Got it. Okay. So Greg asks, if someone had a partial knee replacement of the medial meniscus area 2 years ago and the knee is stronger but gets sore very easily, is there a surgical option other than total knee replacement, such as some type of exploratory surgery?
Yeah, it depends. It depends exactly what the problem is, but one thing that I often see, the only surgical indication that I would feel is appropriate in that circumstance would be if a patient had a lateral meniscal tear, because with the partial knee replacement, your medial meniscus is taken out, but you still have your lateral meniscus. And so if you have a lateral meniscal tear, you could scope the you can scope the knee, and you can trim out or repair that lateral meniscus. I will say, though, that it is less likely the circumstance, at least in my practice, that from what I have seen, that it is a meniscal tear as opposed to patients presenting with a partial knee replacement completed years prior, and they've progressed on to arthritis in either the kneecap joint or the outside portion of the knee joint, the lateral compartment. One thing I will advise patients on is if you've had a partial knee replacement, you cannot have steroid injections or gel injections like you have had before getting your initial knee replacement. That places you at a high risk for infection in a really tough road moving forward if you do catch an infection in that knee. So don't let people put steroid or gel injections in that knee.
Good to know. Thank you very much. That's really helpful information for someone.
Mm-hmm.
Okay, Linda asks, does having had a patellaectomy affect knee replacement?
Yeah, great question, Linda. It does. And, the patella, the way I think about the patella is that it is a link between your leg bone and your thigh bone. So your quadriceps muscles come down and basically converge in a way on your quadriceps tendon, which inserts on your patella, which then inserts to your patellar tendon, which attaches to your leg bone. So when you say, brain, fire my quadriceps muscle, it kicks up your leg bone and your ankle, right? And so without the kneecap, that is compromised. Now, I will say that with patients who have had prior patelectomies, and what Linda's referring to for the rest of the group is that the kneecap is taken out and the patellar tendon is sewn to the quadriceps tendon. It is still possible to extend your leg, but it's done with less force. You don't have the amount of energy or exertional strength of your quadriceps muscle and being able to kick out your leg like you would have with the kneecap. Because the kneecap, what it does is it increases the efficiency of your quadriceps musculature. That is a special type of knee replacement, and it really just depends on your deformity, Linda. If you have bone-on-bone arthritis or near bone-on-bone arthritis and are looking for a knee replacement, it would require potentially one with a hinge type of knee replacement where I connect both the thigh bone and the tibia. And that's what I would consider a complex joint replacement. And but one that I certainly, I find interesting. I certainly find those complex cases interesting. And that is, patients with prior patelectomies can certainly do well with a knee replacement. It just requires a special type of knee replacement, which we can talk about in the future.
Cool. Thank you very much. Kevin asks, once you've had a total knee replacement and it heals, will you be able to kneel?
Great question. What I talk about with every patient who is ready to sign up for surgery or are considering surgery, I bring up a study that was published about 5 to 6 years ago now that looked at tens of thousands of patients all across the country who are 3 years out from surgery. and they were sent a mailer, okay? And the mailer asked simply, yes or no, circle one of those, yes or no, are you able to kneel? 50% of patients are not feeling comfortable with kneeling on that knee. And it's not that it hurts the knee replacement. It doesn't damage what we've done in there. It's not going to decrease the solvency or longevity or the survivorship like we talked about tonight. It just causes you, the patient, discomfort. If you're able to kneel after surgery, I encourage it. I have no problem with it. If you're not able to kneel, I tell patients you have to utilize, a nice set of gel pads if you're tinkering in the garage, or if your work kind of demands kneeling activities, or if you're an avid gardener or churchgoer, certainly a kneeling pad. That is, a large facet of patients require that after knee replacements. And I can comfortably say, based on my survey of the literature and in my own practice, we do not understand the reasons why patients cannot kneel, even in the 90 years of doing knee replacement. And so that's something that we have that is left to discover and to make solvent. But great question, and one that I often get in clinic.
Yeah, thank you. And I have another question, sort of an adjunct to that. Those patients for whom you recommend the gel pad to kneel on, do they then tell you that they can kneel and are comfortable kneeling?
Yes, ma'am.
Okay, great.
Yes.
Good.
No,
Thank
that usually solves it. Or a Scott's Garden pad from Home Depot. Not to throw out a company's name there. I'm not sure if I'm allowed to do that tonight, but or any store for that matter.
Okay.
Just a little bit of a soft cushion or even a blanket, will help.
Great. Thank you. That's great. Ginger asks, after having had one knee replacement, how soon can you do the other knee replacement?
Great question. That really varies based on, your surgeon. And I tell my patients, I say, I want you to get through not only the acute surgical period, but I want you to see the benefits of the knee replacement before you have me do your other knee. I want you to be happy with your outcome before we proceed forward with the other side. So I tell patients, as a general guideline, give it 3 months. Give it 3 months. Now, I have not had a patient that I know of refuse me for the other side. But I do want patients to go through that at first, the first couple of weeks, which is difficult to get through. You're going to be swollen. You're going to be sore. You're going to be using an assisted device for walking. But then after that, you'll see that you will capitulate and make fantastic gains and rather rapidly. And I want patients to get through that before they commit to the other side, so to speak. And so I like the 3-month waiting period. I will also cite a study out of Denver. I believe it was the University of Denver, and this was published about 6 years ago now, where they looked at patients with bilateral, meaning both sides, bone-on-bone arthritis, and the plan was for staged bilateral knee replacements, meaning that you do one side and then you follow up at a later date with the other side. And over 60% of the time, that second surgery was delayed because now patients have a good leg to stand on. Whereas before, where they have painful arthritis on both sides, both lower extremity limbs, they don't have a good leg to stand on, no pun intended. And so, I really believe that giving it time, seeing if you like the approach, seeing if you had a satisfactory result, and having patients know that, and then truly know that moving forward the other side is going to be in their best interest. That's my approach to bilateral staged procedures.
Great. And Donna asks, would you ever do both knees at once for a patient?
That was in vogue about 10 to 15 years ago. In my practice, I do not do that. And the reason being is that I ask a lot of patients post-operatively in terms of time dedicated to that one knee. And what I mean by that is, my approach to rehab is to never give the knee the opportunity to stiffen up. And so the reported rate in the literature of going back and having to break up scar tissue by putting you to sleep in the operating room and breaking up scar tissue, which will form in the knee and prevent range of motion, is close to 5%. And I am far below that in terms of my manipulation rate, and that we call it a manipulation. And the reason being is that I have patients start early and they have aggressive range of motion. I ask you to do 10 minutes of exercise, stretching exercises every 3 hours, followed by a half an hour icing session. And that might seem, minuscule hearing that for the first time, but when you've just had surgery, when you're on some pain meds, when you're stiff, when you're swollen, having to dedicate, 40 minutes of time for both knees, I mean, that's rather arduous. And for patients to keep up on that for 2 to 3 weeks in the initial post-op period, I find that patients don't meet that standard in terms of their ability to complete those tasks. And so therefore, I say I would rather have you focus all of your energy and mind strength on your one knee to make that as good as we can get it, instead of lowering the ceiling for both knees out of the convenience of doing both knees at once. And so my goal is to get you to 130 to 135 degrees at 3 months, which would certainly be in the top 5% of knee flexion in the country at 3 months. We risk that by doing both knees at once. And so that is my approach in terms of that question, which is a great question, because yes, 10 to 15 years ago, people were doing in a much higher incidence both knees at one time. But I think that's fallen out of vogue, especially with younger surgeons doing both at the same time, because we realize the results are not going to be good for either knee, or as good as they can be if they were done in a singular episode.
That makes sense. And you had mentioned that the sooner you gain that flexibility in the knee, the better off you are in the long run. And if you aren't spending time on that knee, you don't put in time to either knee, then you end up having, more limited results. So thank you.
Correct.
All right. So given the length of survivability, says John, there seems to be no reason to wait now that I'm approaching 70 years old. Am I correct about that?
I would say there's a lot of merit to that statement. Yes. However, it depends on what you want out of the knee replacement. There is no doubt in my mind that a total knee replacement feels more mechanical than a partial knee replacement. Meaning that, and studies corroborate this, that a partial knee replacement mimics normal joint kinematics. Kinematics meaning the movement of something. It mimics more normal kinematics of a native knee, meaning God's knee, as opposed to the replaced knee. Mm-hmm. And so for that matter, if you are looking for the most normal feeling knee, even if you are 70, even if you're 80, even if you're 85 or 90, I have no problem doing a partial knee replacement if you meet the criteria that your ACL is intact, that you have no patellofemoral disease, meaning arthritis underneath the kneecap or the outside portion of the knee joint. And so, if you meet the criteria, you can have a successful, long-lasting knee replacement with excellent survivorship. It's when people push the limits on those indications, meaning the criteria to move forward with a partial knee replacement, where they get into trouble with the rest of the knee joint wearing out. And so for that matter, with a surgeon with strict indications for a partial, if you are a patient who meets that criterion and you're 70, 85, 90, a partial knee replacement will suffice and will be excellent for you and will be better feeling than a total. With that being said, though, if you don't meet the criteria, you would be better off with a total, because if you're 70, you're going to be back in the OR at 77 or 75, undergoing a revision knee surgery.
Gotcha. Thank you. That's very helpful. And we have hit 8 o'clock. And even though we have more questions, I want to be very respectful of your time, Dr. Andream. Boy, you covered a lot, and it was great and super helpful. And I know everybody who asked questions, I focused on the ones that talked about joint replacement as opposed to the questions that talked about the different modifications to your lifestyle before replacement. But since the talk was aimed at total versus partial knee replacement, I really wanted you to be able to address those questions for people who are at the point where they need their joints replaced. So Dr. Andream, thank you so much for your time. Thank you for the effort you put into this. And again, thank you for making it so lay available to us lay people who understand all the words that you used tonight. It was really helpful. Thanks for everything,
Okay.
Dr. Andream.
Thanks for having me into your homes tonight, and God bless. Thank you.
Have a great night.